So, diseases of the pulp and periapical tissues. So, the diseases of the dental pulp is delicate. So, the dental pulp is a delicate connective tissue consisting of tiny blood vessels, lymphatics, myelinated and unmyelinated nerves, undifferentiated connective tissue cells, and like other connective tissues, pulp reacts to the bacterial infections or to other stimuli by an inflammatory response known as pulpitis, which causes odontalgia or toothache. So for the etiology, it is here above. So anachoresis is a phenomenon by which blood-borne bacteria, dye, pigments, metallic substances, foreign proteins, and other materials are attracted to the site of inflammation. Anachoretic pulpitis, the bacteria circulating in the bloodstream tend to settle at sites of pulpal inflammation, which might follow some chemical or mechanical injury to the pulp. The phenomenon is due to increased capillary permeability. So for what is pulpitis? Pulpitis is inflammation of the dental pulp, which can be acute or chronic. So for the type of pulpitis, there is acute or chronic. So the acute may be reversible and irreversible. As for chronic, closed and opened or hyperplastic. So for acute reversible pulpitis, so the etiology has dental caries, cavity preparation, thermal changes, and large metallic fillings. So for clinical features, the pain is mild to moderate, and the etiological factor is obvious because it has dental caries and stuff. So for the histopathological features, it will be here. So these are the microscopic sites. So for the acute irreversible pulpitis, acute dental caries, pulp exposure, and severe irritation. So the clinical features, the pain is severe, spontaneous, and continuous. Little response to simple analgesics. So for the histopathological features, inflammation involves the whole dental pulp, vascular dilation and edema, inflammatory infiltration, odontoblast near to the cause are destroyed, formation of a minute pulp abscess. In a few days, pulp undergoes liquefaction or necrosis. For the treatment is root canal treatment. So this the microscopic features. So for chronic pulpitis, the previous acute pulpitis, so the chronic dental caries and the clinical features, the pain is absent or mild to moderate, dull ache and intermittent. Reaction to thermal changes is reduced in comparison to acute pulpitis. So for the histological features, mononuclear cell inflammatory infiltration, evidence of fibroblastic activity, minute abscess, if exists, it is localized by granulation tissue. So for the treatment, it's root canal treatment. So again, the microscopic features. So for the chronic hyperplastic pulpitis or pulp polyp, so for the etiology, open cavity, starts as chronic or acute, wide apical foramen. The clinical features, red, pinkish, soft nodule protruding into the cavity, almost in children and young adults, relatively insensitive to manipulation, and the most common in deciduous molars, must be different from gingival polyp. This one. So for the histological features, the polyp surface is covered with stratified squamous epithelium and may be derived from gingiva or from freshly desquamated epithelial cell of mucosa or tongue. The polyp consists of granulation tissues and it contains delicate connective tissue fibers and blood vessels. So, mononuclear inflammatory cell infiltration, RCT or extraction of the teeth. There. So, the difference of reversed pulpitis and irreversible pulpitis are here in the slides. Posterior. So, for the disease of the periapical tissues, acute periodontitis, apical periodontitis, which is acute or chronic, periapical abscess, periapical cyst, and osteomyelitis. So for the acute diseases of the periapical tissues, this one. So apical periodontitis, the acute inflammation of the periodontal ligament around apical portion of the root. So the cause is the spread of infection following pulp necrosis, occlusal trauma, in endodontic procedures, and etc. So the types are acute apical periodontitis and the chronic apical periodontitis. For the acute apical periodontitis, thermal change does not induce pain. Slight extrusion of tooth from socket, cause of tenderness on mastication due to inflammatory edema collected in the periodontal ligament, due to external pressure, forcing of edema fluid against already sensitized nerve endings result in severe pain. So radiographic features appear normal except for widening of PDL space. There. So for the histologic features, it is there, posterior, and the treatment is selective grinding of inflammation due to occlusal trauma, or you can do it through RCT. So for the chronic apical periodontitis or the periapical granuloma, most common sequelae of pulpitis or apical periodontitis. If acute, when left untreated, turns to chronic. Periapical granuloma is localized mass of chronic granulation tissue formed in response to infection. But term is not accurate since it doesn't show true granulomatous inflammation microscopically. So for the clinical features, it is there, posterior, as usual. So for the radiographic features, thickening of PDL at root apex as concomitant to bone resorption and perfilation of granules appears to be radiolucent area, thin radiopaque line or zone of sclerotic bone, sometimes outlining lesion. Long-standing lesion may show varying degrees of root resorption there. So for the histological features, it is there, posterior, there. And the treatment and prognosis, extraction or RCT with or without apicoectomy. So residual cyst, type of inflammatory odontogenic cyst in edentulous alveolar ridge, occur due to extraction of tooth, leaving periapical pathology untreated or incomplete removal of periapical granuloma or cyst. For the radiographic features, round or ovoid radiolucency in alveolar ridge, lumen may show radiopacity, dystrophic calcification. For the treatment and prognosis, cyst should curated and lining should be subjected to histopathological examination. So the periapical abscess developed from acute periodontitis or periapical granuloma, acute exacerbation of chronic lesion or phoenix abscess, caused due to pulp infection, traumatic injury, pulp necrosis, irritation of periapical tissues, or endo procedures. For the clinical features, so tenderness of tooth which relieves after pressure application, extreme painful tooth extrude from socket, extension to bone marrow spaces produce osteomyelitis, but clinically considered as dentoalveolar abscess, swelling of tissues. Chronic abscess generally presents no features since it is mild, well circumscribed area of suppuration which spread from local area. So the radiographic features, it's there. So for the histologic features, area of suppuration composed of PMN leukocytes, lymphocytes, cellular debris, necrotic materials, and bacterial colonies. Dilation of blood vessels in PDL and bone marrow space. Marrow space shows inflammatory infiltrates. Tissue around area shows suppuration containing serous exudates. So for the treatment and prognosis, it is there. RCT is number one treatment for it. So it is there again. So for the osteomyelitis, the word osteomyelitis originates from the ancient Greek words osteon and myelinus, bone marrow, and literally means infection of medullary portion of the bone, inflammation process of the entire bone, including the cortex and periosteum. So for the predisposing factors, it is there the local and the trauma. For the local, trauma, radiotherapy, Paget's disease, osteoporosis, major vessel disease. For the systemic, immune deficiency, immunosuppression, diabetes mellitus, malnutrition, and extremes of age. So for the classifications, they are classified into two groups, acute and chronic. Suppurative osteomyelitis, myelitis, and non-suppurative osteomyelitis.